Assalamu alaikum everyone. Today we will discuss about acne vulgaris. So it is most prevalent chronic skin condition in the US. It usually affects the people by the age of 11 to 12 year and usually disappear around 20 to 30 year and more common in male during adolescence while more common in women during adulthood. What is the underlying etiology? So genetic predisposition, hormonal factor like increased androgen during puberty in male, it leads to increased production of the IL sebum production by the sebaceous gland, and in a woman usually occur during menstrual cycle due to fluctuation of the hormone level. Another mechanism is follicular hyperkeratosis. So higher keratinocyte activity leads to more keratinocytes production, and there will be decreased keratinocyte shedding in pilosebaceous unit, so lead to the formation of the comedones, which are skin colored papules, and this leads to the bacterial colonization with Cutibacterium acne, formerly known as Propionibacterium acne, leads to inflammatory reaction with formation of papule, nodule, pustule, and cyst. What are the risk factors? So we have external factors and external factors. Then clinical features, so commonly found in the area where the sebaceous gland are present in large amount, like face, shoulder, upper chest, and back. We have non-inflammatory acne and inflammatory acne. Non-inflammatory is also known as comedonal acne. We have two types of comedones, open and closed. Opens are blackheads due to oxidation because they are exposed to the air. So there will be dark and open portion of the sebaceous material. Closed comedone, also known as whiteheads. These are closed small round lesions that contain whitish material, sebum, and the shed keratin. Inflammatory acne affected area are red and can be painful. We can have papular or pustular acne, where we can find papule pustule that arise from the comedones, and we can have nodulocystic acne, usually greater than 5 mm in diameter, commonly found on the back and the neck. And the severe form of the nodulocystic is known as acne conglobata, associated with cyst and abscess. Now, classification according to the severity, we have mild acne in which we have few comedones and papule and pustule may be present. Moderate acne, we have several comedones and inflammatory papule and pustule, and nodule may be present. While in severe acne, we have extensive skin involvement, multiple comedones, papules and pustules, and nodules and cysts. Patients with inflammatory acne are risk of scarring. These are the different types of images. Acne vulgaris on the back of the patient. This is the severe form of the nodulocystic acne known as acne conglobata, and this is another picture which show acne vulgaris. This image also show acne vulgaris. This is another image showing nevus along with acne vulgaris, and this image also show these lesions of the acne vulgaris. Acne vulgaris diagnosis, so it's a clinical diagnosis and considered diagnosis if underlying pathology or alternative diagnosis is suspected. So diagnostic studies are done in these conditions. These are the differential diagnosis: skin and soft tissue infection, hidradenitis suppurativa, pseudofolliculitis, perioral dermatitis, and malaria. Initial management, so perform thorough evaluation and provide supportive care and start initial therapy based on the severity of the acne. Early pharmacological treatment is recommended to prevent complications. Supportive care, so provide general skin care like facial cleaner and avoid excessive cleaning. Avoid skincare products and do not pick at acne lesions. For individuals with endocrine related acne, recommend maintaining a healthy BMI, and dietary restriction and supplements like fish oil are not supported by current evidence. Overview of the pharmacological therapy. So prefer initial treatment regimen is based on the lesion type and the severity of the acne. So for mild acne, remember we give topical treatment with any of the following. Like you can give benzyl peroxide or retinol or a combination of topical therapy can be given, like benzyl peroxide with topical antibiotic or benzyl peroxide with topical retinide, or a combination of benzyl peroxide, topical antibiotic, and topical retinide. So these are the different combination. If the first line are not effective or the patient having some contraindications, so we can give second line. So try any of the following topical treatments like azelaic acid and calcicoterone, which is anti-androgen. Then we have second type is moderate acne. So for moderate, we can give combination topical therapy or a combination of oral antibiotic and topical like retinide, benzyl peroxide plus antibiotic if needed. So either a combination of the topical is given or a combination of oral antibiotic along with this topical is given. If the first line are not effective or there are contraindications, so trial a different oral antibiotic or combination therapy, topical therapy. For female of reproductive age, so add hormonal therapy like combine oral contraceptive pills and consider oral isotretinoin. Severe acne, so oral antibiotic plus combination of topical therapy, or you can give oral isotretinoin. Alternative or second line, so trial of different oral antibiotic, and for female individual of reproductive age, so hormonal therapy is given. Isotretinoin, remember isotretinoin and tetracycline should not be prescribed concurrently as both can cause medication-induced intracranial hypertension, which is known as benign intracranial hypertension. So in topical therapy, we have topical retinoids, which are vitamin A derivative with anti-inflammatory and comedolytic effect, used as monotherapy for comedonal acne or adjunctive therapy for acne of any severity. Commonly used agents are tazarotene, adapalene, alone or in combination with benzyl peroxide, and tretinoin alone or in combination with clindamycin. So we have commonly used topical retinoids are tazarotene, adapalene, and tretinoin. Benzyl peroxide can inactivate retinine. Advise patient not to apply both at the same time. Topical retinoid are contraindicated during pregnancy. So remember that these are contraindicated during pregnancy. Topical antibiotic, and they can both bactericidal and anti-inflammatory effect. Commonly used agents are clindamycin alone or in combination with benzyl peroxide, and erythromycin alone or in combination with benzyl peroxide. So antibiotics are usually given in combination with benzyl peroxide. Avoid using topical antibiotic as monotherapy and limit the length of therapy to 12 weeks to prevent the development of drug resistance bacteria. Now we have other topical agents. These are the agents that can be given. Then we have oral antibiotic therapy. So in antibiotic, we have first line or tetracyclines like minocycline, doxycycline, tetracyclines. Alternatives are macrolides like azithromycin and erythromycin. Alternative oral antibiotics are not recommended for treating acne because of limited evidence, but can be considered if preferred regimens are not tolerated or not acceptable, for example, during pregnancy. Always combine oral antibiotic with topical therapy and limit the treatment to less than 4 month duration. Now we have hormonal therapy. So in hormonal therapy, we have uh, combined oral contraceptive pills can be used alone or in combination with other. And what are the indication acne in patients seeking contraception? Consider in female individual of reproductive age with acne and symptoms of hyperandrogenism, symptoms that worsen with menstruation, and limited response to other acne therapy. These are different combinations which are FDA approved, and this can be given to the patient. Users of progestin only contraception often report worsening of the acne. It is unclear what impact the new progesterone pill containing drospirenone, an anti-androgenic progestin, has on hormonal acne. Then we have aldosterone antagonists. So spironolactone can be used for hormonal acne, can be used in combination with combine oral contraceptive pill or as an alternative for patient with contraindication to hormonal contraception. Contraception is generally recommended for women of reproductive age who are taking spironolactone, which can give anti-androgenic effect on developing fetus, like feminization of a male fetus. Now we have isotretinoin therapy. Isotretinoin is a vitamin A derivative and it decreases the concentration of Cutibacterium acne and inflammation. Indication are severe acne, nodular acne, and the acne not responding to the standard treatment, and moderate acne requiring therapy escalation. Contraindication, absolute contraindication include pregnancy, female, individual of reproductive age, not using contraception, breastfeeding. While relative contraindication include hyperlipidemia, risk factor for hyperlipidemia and liver disease. Avoid isotretinoin during pregnancy and in female individual of reproductive age, not using contraception because of the risk of teratogenesis. So teratogenesis should be avoided during pregnancy. Before initiating isotretinoin treatment, 1 month prior to the treatment, so perform the first two serum and or urine pregnancy tests to confirm the patient is not pregnant. Provide counseling and initiate two methods of contraception. One is primary and another is secondary, which is barrier contraception. Repeat pregnancy test after 30 days of using the two approved forms. Prior to starting isotretinoin, obtain baseline liver chemistry, cholesterol, and triglyceride, and stop any medication that may interact with isotretinoin, for example, oral tetracycline. Now, ongoing management of isotretinoin therapy, so schedule monthly follow-up, assess for adverse effects, confirm contraceptive use, perform pregnancy tests, and for patient with severe acne, up titrate isotretinoin after 1 month. Monitor liver chemistry, cholesterol, and triglyceride, and treatment duration is usually 15 to 20 weeks. Patient planning to conceive should discontinue treatment at least 1 month prior to the conception. Cytopenias can occur with isotretinoin use, but there is insufficient evidence to recommend routine monitoring for the CVC. Adverse effects of the isotretinoin. So we have dermatological effects, dry skin, cheilitis, alopecia, acne fulminans, metabolic like increase triglyceride, cholesterol, glucose, liver chemistries like increased SDLT and acute pancreatitis, hematological, neurological, ophthalmic, musculoskeletal, non-specific symptom, drug interactions like with tetracycline or contraceptive, and possible delayed wound healing after elective procedures. Another we have fetal retinoid syndrome, which is leads to congenital CNS defects, cardiac conditions, congenital craniofacial anomalies, and other like thymic hypoplasia and PTH deficiency. Individual taking oral isotretinoin should be monitored for symptom of suicidal ideation and IBD, even though there is insufficient evidence. Complications are secondary bacterial infection, post-inflammatory hyperpigmentation, scarring, and psychological distress. Infantile acne, so more common in boys, affect less than 2% of the children, and age of onset is usually greater or equal to 3 months. There is papulopustular rash and closed comedones. Severe cases may develop nodules and cysts, can last 1 to 2 years, may cause scarring, especially in children with darker skin. Treatments or topical treatment like benzyl peroxide, erythromycin, azelaic acid, and retinoids. In severe cases, consider systemic therapy with oral erythromycin or isotretinoin. Neonatal cephalic pustulosis resolve without treatment, but infantile acne require treatment to prevent scarring. So that's all about acne vulgaris.